And welcome to my project entitled Evidence-Based Change Project Proposal for the course MSN Role Development here at Post University. My name is MBerzonsky and I am an MSN student here at Post University. So my topic for this project is a palliative consult pathway protocol that I've developed in response to an issue noticed on the unit. I'm currently a med-surg oncology nurse, and we've noticed a delay in access to palliative care for patients who may benefit from palliative care. So the proposed change is a palliative care consult pathway, and it's a specialized pathway, almost like if you're familiar with Epic, a flow sheet that would trigger a palliative care consult once the patient hits a certain criteria. So this would include a specialized palliative training for the nursing staff, physicians, and it would include this technology-driven flag that would pop up similar to if you're familiar with a wound care consult protocol in Epic. Once the patient is recognized to have a wound, you can order a consult directly through Epic. It would go to the clerk and then to your wound care nurse. Similar idea here with palliative. So that would include a patient assessment and then a care team meeting after these flags were addressed, and then introduction to a family discussion about palliative care, and then implementation of the plan that we come up with the family. So why do we need this change? This change is especially important here because there's a significant delay in pain management and palliative care, not just in the US or here in our local units, but there's a current delay in palliative care on a global scale. So a study in Brazil highlights an average 5-day delay in palliative consultation, and a UK study by Craigs et al. Revealed disparity in palliative care distribution, highlighting patients were less likely to receive palliative care if they were male, aged 80 years or over, diagnosed with lung cancer, had not received an opioid prescription in the past, or had never received chemotherapy. There's also a lot of confusion and uncertainty among family, especially with a patient who has multiple chronic conditions. Maybe they're towards end of life, that they're not really sure kind of what the plan is, what we're doing, and there's also a lot of uncertainty among staff in terms of, what the plan is, getting the pain management that the patient requires, and the other resources. So in response to this change, we would hope to see an increase in patient, family, and staff satisfaction, as well as a decrease in financial costs, which is an unknown benefit of palliative care. A study by Kim et al. States that the use of palliative care was significantly associated with decreased hospital charges, and a study by Yedev et al. States that most included studies showed that palliative care reduced the cost of health care by $1,285 to $20,719 for inpatient palliative care, $1,000 to about $5,000 for outpatient and inpatient combined, around $4,000 for home-based, and $117 to $400 per day for home hospice, combined outpatient and inpatient palliative care. So that's also something that can be really beneficial, especially with, as we all know, the financial constraints of healthcare can be a big stressor for families. So a theory that would support the change of this, that I would use to support the change of this on the unit, and one of my personal favorite theories, is limited change theory. The first step of this theory involves unfreezing. So this is the goal of this step, according to Scott and Thompson in RN to MSN Principles of Professional Role Development, is to reduce the amount of resistance to change and show why the change is necessary. So this is to prepare the staff of the change, educate the staff of why the change is needed, and hold informational sessions about this change, kind of warming the staff up to this change that would be coming. The next step is actual changing process, and it is implementing the new practice onto the unit. In this case, it would be implementing the use of this new flow sheet, this new consult tool for palliative care. And a common misstep with this section of the theory and the change process is not allowing enough adequate time for the staff to adapt to this change. And it's really important that you allow enough time for the staff to get to know the tool, use the tool, and really understand the tool, because rushing this phase can cause staff resentment to change and resistance. The final step in this theory is freezing, which is moving the new change into practice, and then creating a habit, making this a habit, fully embracing it and it becoming almost the new norm of practice on the unit. As we know, there are several barriers with any new change we're implementing, but especially with this palliative care tool, as palliative itself can be a very, not necessarily controversial, but a touchy subject. According to a study by Nazreen Lalani and Yoon Kai, barriers to palliative care include lack of trained palliative care providers, late involvement of inpatient palliative care and community hospice services, inadequate palliative care education and training, financial barriers, attitudes and beliefs around palliative care, and geographical barriers. So something we've really seen in our unit in terms of barriers is a lack of family knowledge about palliative, a lot of emotional response to palliative. Sometimes there's a misconception that palliative means end of life and that their loved one is going to die very soon. That's not necessarily the case. Palliative care is just focused on increasing quality of life and pain management. It is used hand in hand a lot of times with end of life care, but it can be started at a much earlier point in the chronic illness management plan to kind of help the patient with quality of life overall. Another one we've noticed is provider hesitancy, in that there's a belief that palliative care means stopping all active treatment. This is especially common amongst older providers, and there's a hesitancy to collaborate with other specialties that they can view as opposition. They can be a bit territorial about their patients. Another one is nursing staff training and confidence, and this can be one of the biggest reasons why there's an issue implementing these palliative care conversations, and nurses admitted to a lack of confidence out bringing up these conversations, especially when they're not sure what the plan is with the provider and kind of what they've already spoken about with the patient, as well as lack of overall confidence, especially if it could often evolve into more of a potential conflict, as these can be emotional conversations. There are many ethical principles that are recognized in healthcare in general, but especially important in palliative care and the implementation of any new palliative way of care. And they include autonomy, non-maleficence, beneficence, justice, and fidelity. Autonomy refers to the patient's right to self-determination. So what happens a lot of times in our palliative care systems is the patient cannot make their own decisions. They're no longer able to. So what we do in that point is we follow advanced directives, which is the most appropriate way, living wills, healthcare POAs and proxies, and DNR orders. Non-maleficence is a huge one in palliative care. It refers to the principle of doing no harm and minimizing harm to the patient. This is especially important in that there comes a point in our care that when is continuing all measures doing more harm than good to the patient, and that is a critical conversation to have in these consults when we can bring them in early and get everyone kind of on a similar wavelength and kind of see what the family knows, see what the provider knows, and kind of start that conversation early to minimize the harm done to the patient. Beneficence is doing the most good in any situation. Justice is fair distribution of healthcare resources. This tool would hopefully allow more access to palliative care to a broader range of patients earlier on in their healthcare journeys, and fidelity is honesty in providing honest care, which is especially important in palliative in terms of honesty about all the options on the table and prognoses. Another really important resource for us is ethics committees and getting them on board with any of the palliative care situations, especially when there is a conflict between maybe what the patient and the family want. Legal considerations go hand in hand with our ethical considerations in respecting patient autonomy in the POA. When the patient is no longer able to make decisions, we follow up with the POA or next of kin and any advanced directives. And there are many HIPAA considerations, especially with the implementation of this new palliative care tool, in maintaining patient privacy, controlling the spread of health information, as this tool would involve the electronic health record, and an implementation of a new electronic tool. We want to make sure that all that information is protected. Cultural care is a huge part of palliative care in terms that, according to Gibler, cultural background influences how patients make pain and palliative care decisions. Some cultures place a substantial value on the community, while others encourage individual independence. So two main cultural points that we're going to focus on here is the expression of pain and healthcare decision making. So culture influences the expression of pain, and that some cultures, while experiencing pain, may remain very neutral and stoic, and others are very vocal. We want to make sure we're giving fair care to all of our patients, regardless of their cultural presentation, in terms of maybe a patient is very stoic in how they express their pain, but we want to make sure, like, even though they might look okay on the outside, we're still doing those focused pain assessments and giving them the um, pain protocols that they may require. Another one is healthcare decision making, in terms that different cultures have different ways of making healthcare decisions. Some cultures it is left to the patient to decide, some it's up to the elders, and some it's up to the men of the community. It's the utmost important rule to follow in culturally competent care is respecting and following the patient's of the wishes, including family when indicated, and offering alternative options for pain management, as a lot of different cultures also are not as open, or it's not as culturally appropriate to them to take or prescribed controlled substances or certain pain medications. We want to include things like herbal medications when indicated, or acupuncture, acupressure, those types of things. Expected outcomes from the implementation of this palliative care tool includes a decreased time between admission and palliative care consultation, increased access to palliative care for patients with chronic conditions, increased patient and family satisfaction, and these outcomes can be measured through chart reviews and chart numbers, including the number of palliative consults per patients with chronic conditions, the number of admission days on average versus when the palliative care consult was put in, and patient satisfaction surveys. So a leadership style that would most benefit the implementation of this palliative care tool would be the democratic leadership style. According to the National Society for Leadership and Success, democratic leadership encourages collaboration, asks for group feedback, is flexible, values communication throughout the team, and it is considered one of the most effective leadership styles, which I've agreed with and seen on the unit. It gives the team a chance, everyone as part of the team, to put feedback in and kind of come up with this plan together, and they're more united in implementing this change for the patients. Organizational leadership is crucial in this implementation of this change, in that it is a system-wide change. It involves multiple facets of care and how the system operates, and it affects finances, it's multidisciplinary, it affects nurses, physicians, chaplains, religious, ethics, like all systems. It involves staffing and staff education. We may need to implement more non-clinical days for staff to attend educational sessions, and we really do need the support of administration in the implementation of this tool if we are to be successful. Key stakeholders, the first one's obviously the patient and their families. This is directly who the change would be affecting, who the change is directed towards. It affects nurses and physicians in terms of affecting workflow. It changes orders, order sets, and the care that's given. It affects hospital administration, and that it's a change system-wide. It affects finances, staffing, and it involves them championing the use of this tool and really supporting this on the units. It affects insurance companies in terms of it changes the cost of care potentially with palliative care, and it changes how services are billed. And then case management, it affects placement, including referrals and the type of support given, rehab versus hospice versus home health. It is an interprofessional change, and it involves nursing, physicians, administration, ethics, informatics, support staff, chaplains, basically anyone involved in patient care it's going to affect. And we can ensure successful collaboration interprofessionally through the use of interprofessional meetings, frequent communication, just keeping those lines of communication open, email chains, group text, such as Tiger Text, that's a common healthcare field group text message that's really beneficial in keeping communication. Informatics is a key part of this project in that we have an electronic technology change. Informatics is defined as the integration of nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. So it's really important in this project that we work closely with our nurse informaticists to develop the technology necessary for this palliative care screening tool, and to create this auto consult trigger and make sure it flows smoothly between nursing and physicians and providers and anyone else that may need access. This project has been pretty insightful, particularly into not only getting a better view of palliative care in our U.S. healthcare systems, but also on a global scale. It seems to be an issue that we're dealing with globally, and an MSN preparation would better prepare one to implement this change on the unit, in that the MSN preparation gives you a better scope and background to the bigger issues in nursing. as well as driving forces that you can use to implement change, such as theories and organizational policies. And a lot of times these changes come from MSN prepared nurse roles, such as management, educators, or other advanced practice perspectives. I would definitely consider implementing this plan only after discussing with my coworkers on the unit and getting a um, better idea of the feedback of our palliative care consults currently and seeing what their intake is of the issue, meeting with our palliative care team providers to kind of see what their thoughts are, and then only then, once I kind of have feedback from everyone, I would consider proposing this change. And here are my references. Thank you very much for joining me.